Welcome to the premiere edition of Simple Medicine. I'm Jay Fox along with Dr. Rob Barkett Jr., who is, in fact, the author of this book, Simple Medicine. And every week when we do this podcast, we're going to be addressing a different health concern. First of all, congratulations on the book and starting a podcast. This is exciting stuff.
Well, thank you very much, Jay. This has been kind of a dream of mine as the years went on, and I have to thank COVID that it gave me some extra time out of my schedule when the office practice wasn't quite so busy. And I just started writing. Every year I would review internal medicine, and this year I just started writing on certain common topics and disease states, complaints that I've seen over the past 30 years in medicine, and just a labor of love.
So was the intent to just ruminate and write, or was the intent to create a book, or did the book just evolve?
No, the intent was for the patient.
Okay.
I thought patients needed more education, they needed to be more literate in medicine of their own conditions, and I don't think as doctors we do a good enough job, even though, of explaining the conditions and the tests that the patients are having and why we make certain decisions in their certain disease states. And if we do tell them, when we do tell them, we know that they forget about 80% by the time they walk out the door.
Well, I would imagine, because as a patient, sometimes I find the experience with the doctor to be overwhelming. Sometimes I find when I'm being told something by a physician, I have a cursory understanding for what the physician is saying, but then the language gets so in-depth that I get lost in the minutia. And that's when I'll do something like go to Google or WebMD, and then of course every time I have every disease known to man.
Well, medicine is like talking Chinese. The nomenclature, the words, I mean, some of these words I can't even pronounce either, but it's very, very difficult to understand, even though I try to, talk in layman terms to the patients. If all of a sudden they've heard the word cancer or diabetes, or their head is spinning,
right,
and they're not able to concentrate, not able to focus, and their spouses will tell me, well, when they get home, what did you talk about? I can't remember.
Yeah. Well, we're almost 30 years since the advent of the internet, which was supposed to be this great information superhighway. But what has that done to the patient in terms of self-diagnosis?
It's really made a lot of people go down the rabbit hole. They can Google whatever they want, and there's keywords, and next thing you know, they're dying and they have the weekend to live. And part of this book is a patient story.
Right. Well, you say no more Google searches right here in the front cover.
Well, this gentleman, he's an educator.
Okay.
And very smart. And I see him every, 4 to 6 months for his regular checkup. And he came in and he immediately needed to be seen. Now, usually my radar's up. So if I get a patient that I've known for a while, I'm like, oh my gosh, something's really bad's happening.
Right.
So we got him in early that morning, and he had peed blood the night before and went to Google, and he has kidney cancer.
Yes, absolutely.
So we get in
with 2 weeks to live at most.
At most. So we came in. I tried to get him from jumping off the cliff, and I told him what the differential diagnosis, and he had some discomfort. I'm like, I'm pretty sure this is a kidney stone. Sure enough, it was a kidney stone. So he brought me in a poster that is still in our front office here, and it says, "Don't confuse my Google search with your MD."
That's absolutely true.
And that was another impetus for me. And then I looked around the internet to see if there's any medical guideline handbook just for the patient.
Right, because online you have something called WebMD, but much like Google, if you type in your symptoms, it's going to list 15 different potential maladies. So you don't know.
It scares me, and even when I'm in the patient room, because we have the computer, which I dislike, but that's another topic. And I'll Google some words or how to explain it better, and it's confusing, and it takes you to areas you don't want to go to. So I can imagine what it would do for the regular patient.
Absolutely. When I was a child, we had a housekeeper, and I will never forget this. I remember I offered her a cookie that we had gotten from Huff Bakery, and she refused it. And I said, Aunt Pearl, why won't you eat the cookie? She said, I have the sugars. And I said, you have sugar? No, I have the sugars. I said, well, what does that mean? She says, I can't eat the cookie. But that was the language that was used in that community at the time. So what are we talking about? We're talking about diabetes. What is the difference between type 1 and type 2 diabetes? It's always confused me.
Well, generally, they're both very genetic and oriented. So if you have a family member with diabetes or some other autoimmune disease like rheumatoid arthritis or lupus or hypothyroid, there's a good chance you can acquire it. Well, type 1 is basically juvenile diabetes.
Okay.
And
when you say juvenile, is that between the ages of 0 and 18, or can that extend to 25?
I don't really use too much of a time frame, but yes,
Okay.
anything under 18
Anything
is
under
juvenile.
18.
And if I see anything, I have not really ever picked up a type 1 diabetes. The pediatrician has already taken care of it. And then type 2, which is really genetic, is adult onset diabetes, and for the most part caused by obesity.
Diabetes mellitus, correct?
Correct.
Okay. See, I even pronounced it
Yes,
correctly
yes,
this
you
time. So, what constitutes obesity? And don't look at me and point to the camera at the same time, because that's rude.
Right.
But what constitutes obesity? How do we know?
The easiest method for us now as physicians is the BMI, the body mass index.
Okay. And what is that?
It's just
comprise?
a chart, height,
Okay.
weight, and you go to it.
Okay.
31 is considered obese. 35 if you have comorbidities like high blood pressure, high cholesterol, diabetes, heart disease, and then morbid obesity is greater than 40.
Okay. So it stands to reason, and this may just be a layman's perspective, but over the course of the last 30 years, people seem to be getting bigger, which means more and more people are over 30, 35, or 40.
Well, I think genetics again plays a big part of this, and those patients do have a predisposition. I think in the changes in eating habits, physical habits over the past 30 years. You can't go a block anymore without a McDonald's, a Wendy's, a Applebee's, a Chili's, you name it.
Right.
Single parent versus households, fast food restaurants, late night events. People no longer, the children in those areas are, if they are doing their sports, they're not just doing them in a particular town or county. They're traveling state and
And the bus goes to McDonald's and get our quarter pounder with cheese, fries, and whatever, and we're on our way. Why is that quarter pounder with cheese and fries so bad for us?
What's the carbohydrates?
Yeah.
People think, well, I don't eat a lot of sugars, doc, so why am I gaining weight and why is my sugars getting worse? Well, they forget about, that's sugars are just, you put them in, you get a little energy, they're in, it's out.
Right.
The carbohydrates stick with you.
So those carbohydrates come from the bun, correct?
Yes.
It's the bread.
Yes, it's the bread.
So if we were to eliminate the bread and just eat the insides,
Well,
that
then you
would
get
be,
the toppings.
Then you get the toppings.
You get the mayonnaise and
ketchup.
ketchups and all that go with that.
And those have carbohydrates as well.
Yes.
Okay. So let's take the toppings off. What about the meat and the cheese?
I'm okay with that.
Okay.
Yeah, I'm okay with meat and cheese, and when I talk about diet with my patients, it's easier that I've kind of just come up with the 4 P's.
Right. And
So
what are
the 4
they?
P's, which are pea, potato.
Okay.
Pea.
So no French fries.
Right.
Right.
Which come with the sandwich.
I know, that's terrible.
Pea pasta.
Really? All pasta?
Most pasta. You got some healthier pastas.
What about Dreamfields and the low carbohydrate pastas?
In moderation.
In moderation.
Always in moderation and serving size.
Right, so you've taken my two favorite things off the table, pasta and potatoes.
And then pea Panera bread.
Oh, okay. Oh, that's cute.
You adding a little more, and pea pastry. Sweets.
All pastry?
All sweets.
Anything that's sugared.
Correct.
Okay, so
All four major food groups for most people.
So I'm going to play devil's advocate and ask this question. I'm going to lose the potatoes, the pasta, and the bread.
Or moderately back down.
Or moderately back down.
And again, no one uses the serving sizes that we had when we were kids.
But I'm going to... Yeah, oh, absolutely. Well, you know, back in our day, if you didn't clean your plate, there was a problem.
Big problem.
So it was a behavioral issue, not just a chemical issue.
Correct. And it was home-cooked meals.
Oh, absolutely. But now what we're saying is, if you're going to normally serve on a 12-inch plate, back that down to a 10-inch or an 8-inch plate.
Correct. Absolutely.
Or cut your portion in half and save that for another meal.
I love that idea. I try to preach that.
Okay. So back to the concept of sugar. Why is it that when we substitute sugar with either aspartame or Splenda, which I think is sucralose, or saccharin, which is the pink, or stevia, which is the green, why do we seem to crave more sugar?
That's a good question. Hits the pleasure center, the dopamine center in the brain. We crave it. It's like sugar.
So it makes it harder
to
walk away from that.
Absolutely, because it hits our pleasure center.
Okay. So what do we do? Do we just eliminate any kind of sweetener?
You know, everything, something has to taste good.
Yes.
Yeah, a little bit. So I'm not against eliminating everything, but again.
But would you rather see a patient use a little bit of sugar or sugar substitute?
I'm not even big on the sugar substitute. If you're going to use a little bit, use the real thing.
Yeah.
But, obviously, if it is it's like pop and diet pop. I think the diet pop has more chemicals that are worse for us than the regular pop.
Mm-hmm.
So, if it, tastes good, because you got to have some pleasure in life.
Right.
But again, I always have cheat days.
Okay.
Every fourth day or something. You've been really good and you're listening to your doctor and you're staying away from the potatoes and the pastas and breads, and you're using more, quinoa, and you're eating your fish and it's grilled and your vegetable. That next day, do what you want to do.
So one day a week I can have pizza?
Absolutely. I think that's the only way, especially myself.
Yes.
And I think people have to have that little carrot at the end of the week,
but in moderation. So I'm not having the whole pizza followed by the chocolate eclair for dessert.
Correct.
That's too much.
That would be too much, but something that you look forward to, and it's like the tap on the back saying, "Hey, good job, well done. Let's have 2-3 pieces of pizza and
sure
a beer and enjoy ourselves."
So going back to the concept of type 2 diabetes, what is the difference between that and hypoglycemia?
Well, it's in how we define the diagnosis.
Okay.
The diagnosis of diabetes can be made in several ways, and if you have excessive thirst, excessive dry mouth, excessive urination, unexplained weight loss, and you have a random blood sugar over 200, you have diabetes. Or in the olden days when I was starting out, you had a glucose challenge where you drink some sugar. 2 hours later, we check your blood sugar, and if it was over 200, you're diabetic. Most of the time, as physicians now, I love the hemoglobin A1C.
Okay.
It's a sugar-coated red blood cell.
Now, hang on, before you go any further, we don't know what A1C means. What?
I was going to say. What the
language.
The A1C is like what I try to explain to the patients. Yeah. It's a sugar-coated red blood cell.
Okay.
Now, your red blood cell, they last about 90 days in your system.
Oh, okay. So they're part-timers.
They're part-time. You're making more from the bone marrow. Then they're leaving the system. Somehow, some way, at the very end of their lifespan, they get coated with extra sugar. Okay. Extra sugar coats these red blood cells. And amazing, allows us to measure what their 90-day average is.
So our body's like Willy Wonka in the chocolate factory. red blood cell just travels, picking up
Travels.
stuff along the
Absolutely.
way.
And if you get, it's a percentage, and 6.5 or greater on your
Okay.
A1C, not just once, but on a subsequent visit, you're considered diabetes. And that's allowed us to diagnose type 2 diabetes at a much earlier stage. Regular sugar levels do fluctuate, and I think we're getting to it. You know, we used to miss the diagnosis 2 or 3 years on average. We would delay our diagnosis on diabetes.
So if somebody is not diagnosed with diabetes per se, but they have the shakes or some kind of fibrillation, if you will, is that an indication that there's something wrong with the balance?
No. The biggest indication we have is most physicians will check a fasting blood panel once a year. And if their fasting blood sugar is between 100 and 125, you know, I make it easy and just say, you know, instead of impaired fasting glucose, I just kind of tell the patient that, hey, you're pre-diabetic. They understand that better.
Sure.
And then I do the A1C. But most time you'll have zero symptoms, even when you're starting diabetes of anything.
Okay.
And some people say, well, hyperglycemia or hypo, they think, oh my gosh, I got to eat all the time or my blood sugar goes too low. But that's a rare disease.
So you would think that there would be a natural journey to a nutritionist as part of this program, but nutrition programs aren't covered by insurance the way they used to be. What happened? Wouldn't it make sense that the two should coincide? I'm diabetic, I have to change my diet. I don't know how to do it. Where's the nutritionist?
That is a fabulous, I don't even know how you came up with that, because again, I've been in practice 30 years, and as soon as we saw that they were pre-diabetic, mostly diabetic, nutrition, I think nutritionists should be the first, second, third, and fourth treatment options.
I would think so, because here's something I never knew. I never knew that fruit converted to sugar. I also didn't know that yellow vegetables converted to sugar. Carrots are full of sugar. I had no idea.
And to say, I am definitely undereducated on nutrition. We, in my day, did not know what they do today, and we weren't educated enough. And if I really was educated enough to go beyond the basics, it would take you a half hour to an hour to go over, on multiple occasions, to go over what a proper diabetic diet is.
Why does it have to taste bad? That's what I want to know.
But I want the viewers to know, as Jay said, insurance has cut rid of the dietitian and the nutritional consult, which just blows my mind.
That seems like a setup for a liability issue.
It's awful. It's awful medicine in today's technology, where I give them some pamphlets, I give them the 4 Ps, I tell them some sites, you know, to go buy a book on nutrition, but they're really having to be self-educated. I myself, I didn't even realize 10 years in my practice, like milk, too much milk, terrible.
I would never have thought that. I always thought milk was great for the bones and great for calcium. And then there's that S word again, sugar.
Yeah. So it's unfortunate in this day and age. They'll pay for all these tests, and you go to the emergency room, you bumped your head, you're going to get an MRI, but they won't, pay $60 for the first 3 treatment options of diabetes by a very good nutritional consultation.
So that being said, when somebody is diagnosed in your office with diabetes, how do you compensate for the lack of that availability? What do you do?
Like I said, we do have some good pamphlets that here on the 1,800 calorie diet, which I really like, and on the portion controls. What are some of the good foods? What are some of the bad foods? And I know I am lacking and doing a disservice by just doing that.
I have an idea, and no, this is not scripted. Why don't we take the camera and go grocery shopping someday? And let's seriously, because wouldn't you like to see that? Wouldn't you like to go grocery shopping with Dr. Barkett to find out what is good considered, what is bad, and why? Because that's what we want to know. Yeah, we want to know that broccoli is good for us, but we want to know why.
Right.
We want to know that we can eat an apple, but we probably should eat the apple in the morning, not at 9 o'clock at night. These are things we need to know.
Yeah, just like the banana. Again, I always think, okay, I'm going to get to my fruit. I found a whole banana has way too many carbs. You got to eat half the banana. Just simple.
Just half a banana.
Yeah. So there's just simple.
I think we're going grocery shopping after the holiday.
I think that
we're
would
take
be
the
good.
camera with us. So we've made the diagnosis. The patient has come in for treatment. How likely is the patient to be able to pull themselves out of type 2 diabetes mellitus? Or is this something they're going to have to deal with for the rest of their life?
Well, once type 2 diabetic, you're always type 2 diabetic.
Right. I guess what I'm saying is, can it be managed and controlled?
We try now. It depends on the majority of the patients. It's incidental. It's abnormal blood testing, and they don't have the excessive thirst, dry mouth, urination,
right.
and if their A1C, is less than 9, and doctors will have their own judgment on, what they'll do. But I always want to give my patient a chance to do it without medication. So
okay.
I don't believe 4 months, because now insurance is only let us check the A1C every 4 months instead of every 3 months, which the test is good for, because I guess that's one less office visit, so I don't
right.
get as tight a control anymore. But I don't think anything bad's going to happen. But I always tell them the only rule about diabetes is there is no rules.
Right.
And so if they do become, with the symptoms, get on in here. But I think every patient needs a chance to do it on their own.
So let's
diet alone.
Right. So
and
let's say that we diet and we exercise, and we've addressed those 4 P's. Do you remember the 4 P's? It's potatoes, pasta, panera, which is bread, and pastry, which is sugars. So we've done all that. It didn't get you to the level that you wanted us to get to. Do we get on Trulicity? Is that the first thing we get on?
That's what every patient wants now.
Why? Why do we know about Trulicity? Is it because of the commercials on television?
Yeah, Trulicity and Ozempic, they are great medicines.
Okay.
And it's breakthrough medicines. It's breakthrough technology, enzymes that I was never trained under. And these medicines, not only are they treating your diabetes, but they're treating blood pressure. You lose weight. Well, you lose weight, it decreases your blood pressure, and they have cardiovascular mortality, means you're going to have decreased heart attacks, decreased strokes, decreased overall death. So why not go straight to that? But there still is an algorithm that I like to lose. And in diabetes, in this day and age, it's algorithms changing.
Mm-hmm.
I mean, and if physicians and special order physicians aren't keeping up to date, I see a lot of referrals from other doctors, or they're retired, and they're on antiquated medicines for diabetes. And I tell the patient now, I am only going to give you medications that are going to help decrease the risk of heart attacks, strokes, heart failure, kidney disease. And we can do those medicines up until insulin. Because the insulin, even though insulins have gotten better and they're longer acting, all they do is lower your sugar level, which is great,
mm-hmm.
or they add weight, which is not good, but they don't decrease the risk of other morbidities and mortality. So I'm always going to start on an algorithm that includes metformin. I think in any guideline now,
okay.
Metformin's been tried and true, and you have to remember the one key ingredient here. It's very inexpensive, because once you become diabetic, you're going to be on a cocktail of medicines.
Okay.
Right off the bat, because once you've turned diabetic, even though you may not be on medicines, you're already at risk of heart attack and stroke. So now we have to treat your cholesterol as if you've already had a heart attack or stroke, and those are different guidelines. So you may come in non-diabetic, and I tell you, hey, Jay, your cholesterol's good. But now you're diabetic, I'm like, hey, Jay, your cholesterol's not so good.
No, right.
And we got to go down and try to get that LDL as low as we can, and it's impossible. without medications, the statins, but that's another story. And then you're going to be on a blood pressure medicine, even if you don't have it, to maybe protect the kidneys, and those are ACEs and ARBs. We'll go over those types of medicines later. And aspirin, I know there's a lot of studies out there, but maybe being old school, I still think a baby aspirin and that could be refuted and by some guidelines of things, but that's just the way I do it.
But I mean, it may work for one patient, it may not work for another, because
Right.
our chemistries are all different. And weight loss is a huge concern in our population today. And some of the major news networks have been talking about the use of diabetes medication, not for diabetes, but for weight loss. What is the risk to a patient of taking a medicine that is for one thing and trying to use it for something else?
Well, in this situation, it's countrywide. We can't, doctors are using these weight loss medicines appropriately and inappropriately, and the biggest one would be Ozempic. Ozempic is only supposed to be used for diabetes, but its name is semaglutide. That is the same medicine as Wegovy.
Okay.
And Wegovy, Rybelsus, which is and we call these GLP-1 medicines, and that's just the name of the class of medicines that they're in. And Rybelsus is a medicine by mouth, where Ozempic and Wegovy is on injection only.
Right.
But the molecule is semaglutide. And so there is no, in this situation, if diabetic or non-diabetic, I don't see there's any harm.
So we're not going to become diabetic because we're taking the medicine.
Oh yeah.
Okay.
So I mean,
So there is an appropriate cross-referencing of this medicine.
in this particular one, absolutely.
Because I would think, as you said at the beginning of this broadcast, weight loss is critical to solving the diabetes, the type 2 diabetes issue. That's the biggie.
Yeah, and especially here, again, it confuses them because yes, being overweight and a genetic predisposition to diabetes, I'm going to tell you to take Wegovy, which is not indicated for diabetes, only for weight loss. But they renamed it Ozempic, which treats diabetes. So it
does get to be very
it gets
confusing.
very confusing.
Well, the whole purpose of this podcast is to put it into terms that you, the viewer at home, can understand. The book is called Simple Medicine. It is available at Amazon. Mm-hmm. Where else is
Barnes
it
and
available?
Noble,
Barnes and Noble.
And most of the online bookstores.
Okay. Dr. Rob Barkett is the author of Simple Medicine, No More Google Searches. He is a physician based in Mansfield, Ohio. And this podcast, also called Simple Medicine, will address these issues and more as we go through 2024. And we are going to take that field trip, and we're going to bring you with us. We may very well do it live. I'm Jay Fox. Thanks so much for watching.